I'll have, if I have a diagnosis of there could be one or the other, a disc herniation, or maybe it's just reactive muscle spasm in the low back. Maybe that's my differential. I'm somewhere in between these two diagnoses. So I'm going to have things that I'm going to put in that if this is more muscular, this is going to help. If this is more disc oriented or structure oriented, this may have no effect or make it worse. And as I go through, I'm gonna have these things, these interventions that are going to help make me more certain of my diagnosis. And that's the testing process. That's the intervention is informing the treatment, is what I'm doing there. So I get through maybe 4 exercises or 4 things that I'm going to do with this person. And I now have each of these 4 things is either going to confirm or deny one of my 2 prospective diagnoses. So then by the time I get through this, they're feeling better or they're feeling worse. Typically they're feeling better because I'm not going to continue to do things that make them feel worse. But even if there are things in that exercise selection that make them feel worse, that's information for me that, okay, these are in the provocative category. Okay, if flexion and rotation of the lumbar spine causes radicular pain down their leg, that's going to be a really strong correlation to this being more of a disc issue than a musculoskeletal issue or a muscular issue. So I'm just compiling this information, and then at the end of that, I can now have a more informed conversation with them, is that this is what I predicted it was going to be, this is how it reacted to X, Y, and Z, and this is now what I think, and because of that, this is the prognosis that I think you can expect. And that's a very realistic way to go about this, where you're informing the process as you go, and there should always be a conversation of, okay, I've seen a disc herniation of this magnitude before, or maybe you haven't, but you did some research, and you can expect that for the next 6 to 8 weeks, you're going to have these systems that are going to be present. I would avoid this, this, and this because these are the things that we already know will make it worse, and I would encourage this, this, and this because these are things that we already know will make it better. And if you can do that, and you can manage expectations in that way, and stretch out the timelines, say that they're probably going to be in pain 8 to 12 weeks, who knows? But if you can get them to feel better in 4 weeks, just by having that informed process, managing expectations, being confident in the things that you do know, being confident in things that you don't know, then that's going to give them hope. It's going to give them buy-in, and they're going to be more receptive to the process. And even if it's not going according to plan, they have that trust, they have that buy-in that you're going to tell them that, okay, this isn't going how I thought it was going to go. Let's pivot, let's change, or I'm going to send you to this person because I need a second opinion.
Yeah, what I like about that is it's, you use the word realistic, but it's actually, it's that, and it's also scientific. Because if you think about the scientific analogy of a single intervention being tantamount to a single study, what you've done there, and what a clinician would call, or what you would call obviously, like a cluster of studies or a cluster of assessments or a cluster of orthopedic evaluations. So for the chiro students out there, sorry, you're in too deep. You got to finish this shit. But you'll get taught clusters. And I think trainers should also have clusters of these things are more alike than different. And these things are different in their own way, but more alike. And then if you start to see results, positive or negative, coming out of these clusters of interventions, it helps form a more robust decision rather than just relying on one data point. So in research, that would be the equivalent of a meta-analysis. We do study after study after study after study. You do intervention after intervention after intervention after intervention. And then the collective, or the aggregate of the results of those interventions, just like the aggregate of the results of those studies, form a consensus. They form a scientific consensus. We call it a meta-analysis. A meta-analysis would kind of be an overlay of all the research on a particular topic and the consensus out of that. So when you build these clusters, you're actually still, again, you don't have to, this sounds bad because people love leaning on the science, and it's usually people who don't have as much experience, which hey, use that to inform your interventions. But over a certain time, the thing that informs your interventions the most is results. Yes. Right? That's the thing. I know a lot of people that will look right past someone who's telling them that a particular intervention that they've derived from science is provocative, and they go, well, this is what the science says. It's well, what about the person, right? Because research-based and evidence-based are two different things. Evidence is a much larger, more clear picture than just research. But you can formulate, just like in research being hierarchical from case study up to randomized double-blind control, and then in randomized control study versus into a meta-analysis, there's hierarchy of evidence on the individual level as well. And you want to, just like at the scientific level, you want to have the highest quality of information through that vector, right? So if you're going to be going through, okay, I need to really play the man on this one. Like, look, sometimes you deal with compounding cases where people have multiple injuries, which actually nullify your ability to stick to the data. Like, comorbidities physically are pretty common, especially when you're dealing with sports. I'd like to do this, but he can't because his ACL, or because his fucking big toe, or because whatever. So it's like, at a certain point, you got to step out of the research world, take a little bit of ownership, but don't lose the essence of science. Use it and understand, how can I now, dealing with one part of evidence, or two, if you have some professional experience, playing the man, playing the patient values, using your professional experience, dispensing with no research that allows you to really, coincide these physical comorbidities. I'm dealing with like a really unique case, which the better you get at it, the more unique cases you're going to get, because like, I've went to everyone else. And it's like, okay, now I'm going to actually just use the rigor of the scientific method on this person. I can't use the outcomes of the scientific method because, sometimes you're dealing with outliers. And sometimes those outliers don't have to be, comorbidities of physical pathology, meaning they have like multiple injuries that would nullify interventions from particular research. Sometimes you're just dealing with people who are really, really freaky strong, or big, or fast, or a combination. And it's like, I don't know if I can use the stuff over here, but I can always use the framework. And I think one of the things, like, to kind of double down on your point, is like, putting these clusters together starts to build the quality of the data, albeit from one of the three pillars of evidence, the interaction you're having and the results you're getting with your patient, client, athlete, whatever your professional designation is. And that is something that you can start to weight more heavily. So I know a lot of people, they go, they do an active straight leg raise. And it's like, disc herniation, SI joint sprain. And it's like, hold on, man. Like, that's the weight of an individual case study, right? It's like, that doesn't hold a lot of weight in the scientific world. We still can take that scientific framework, bring it over to the anecdotal world, and we start to validate multiple data points, either sensitive or specific, ruling things in and ruling things out, to start to build the quality of the data we're collecting in the anecdotal world. And the nice part is we are so proximal to the objective outcome of pain reduction that our results, whether good or bad, should be immediate, which is also one of the benefits of being able to operate in that world. And it's where I think the anecdotal world and the science world, albeit ever clashing when people live on one side of the aisle or the other, I think the scientific method is the thing that bridges the gap, and the anecdotal world needs to adhere to that method and understand that adherence to the method is going to improve the quality of the evidence that you have. It's going to allow you to make better decisions.
Love it. Yeah. I think an important thing to mention along the lines of making better decisions and interpreting information that's already out there, there's a lot of systems out there around low back pain. There's a lot of frameworks that have been set that don't have a robust enough exclusion criteria. Is a pretty dumb way to say it, but true. And I think that there's a lot of people that look for solutions, and they're sold these solutions, maybe out of ignorance, maybe out of lack of experience, whatever it is. But there's a lot of things out there that will tell you that this is what fixes low back pain. And they could be right a lot of the time, but they could also be wrong a lot of the time, because unless you're understanding which situations, not necessarily which situations this applies to, because it's harmless or helpful in the situations it applies to, but it could be harmful or at best non-helpful in situations that it doesn't apply to. So I think that's an important part of this also, is understanding that systems are systems, and they work for the things they're meant to work for, but they're not going to work for everything. And funny we talk about doctors of spine, because this is what chiropractic school taught me more than anything. It's not that there's a system that has the right answer for everything, but it's more so interpreting what a system does and when it applies and the principles that make it true to that application. So if you can look at, I don't know, McGill's Big Three, or you can look at, I don't know any of these systems because I don't buy
McKenzie
into
is one of them. I remember DNS.
Yeah.
They're crawling around a fucking hotel lobby. A lot of chiros are into that.
So the reason that these things are prevalent and they exist.
Some of them are so dumb. Literally,
so
I had to make
dumb.
a comparison to DNS. I was talking to some chiro kids, and they're like heavy into DNS, and I was like, "Okay, do me a favor."
Were they bitches?
Kinda, yeah. And I don't want to throw shade, but like, I literally, it's like, yeah, but like it feels good after. I was like, yeah, I'm sure jerking off with a belt around your neck also feels good, but next time you do that, just put a mirror in front of yourself when you do it. Because if you
look yourself in the eyes.
Right. Like at a certain point, like if you put a mirror on the floor when you're doing it, dog, what are we doing here? And again, there's no way to say no offense and also say that and mean both of them. But like, like at a certain point, like put a mirror in front of yourself when you're doing this and be like, it feels good. It's like, what are you doing?
Yeah.
One of my favorite quotes of all time is by a British statistician. His name is, I swear this has something to do with what you're talking about. His name is George Box, which is like a hilarious name. And the quote goes, all models are wrong, but some are useful.
Okay. Yeah.
It's fucking brilliant.
And that's exactly the point that I was getting at as these chiropractic students are jerking off with a belt around their neck. I hate the world that we live in. But what I'm saying is that if you can look at these and not listen to what they're saying, but distill it down to why it works in that situation, then that's the value of the system, right? That gives you a tool that you can use to solve a problem. It doesn't give you the answer to all the problems. But if I can understand why Q12 chiro kid's jerking off with a belt around his neck, then next time I have that problem, I can shoot myself in the face. But because that's the answer. But if I understand, okay, McGill's Big Three, really what we're doing is it's graded exposure to plane specific anti-movement through the core. Sick. All right, I'm learning to resist movement through all three planes through the core. And I'm doing so in a way where maybe I'm not dealing with the axial compression of gravity. Sick. That's useful. That's useful to know that. It's not useful to start to put dumbbells in people's hands while they're doing bird dogs on a bench and shit like that. It's if you understand the mechanism in which this is causing change, then you can scale that stimulus as opposed to understanding the method in which they're creating change and then scaling the method, right? It's not bird dog better, it's anti-rotate better. And that's what I'm getting at is these systems, they're not complete. And they're a very small snapshot of what will work in specific scenarios. But if you can understand why they're working and the scenarios they're working for, then that's the power that lies within those systems. So yes, there is value in learning these things, but not learning these things to a T. There's the value is interpreting these things and reading between the lines and not getting sold on, McKenzie whatever or jerk off with a belt around your neck chiropractic kid. Don't do that. Understand the principles behind it, and that's what's going to be the thing that allows you to apply that and cross-apply that to not just someone with low back pain, but maybe someone in the NFL offseason that's having trouble stabilizing their pelvis or changing direction. That's what allows you to cross-apply these things, is understanding the root of what's causing change and the specific change that's meant to create.